Good afternoon, everyone, and welcome from Oak Park, Illinois. Thank you for joining us for the first ever joint Grand Rounds and National Hospital Alliance webinar sponsored by WomenHeart, National Hospital Alliance, and Rush Oak Park Hospital. In addition, this is the first WomenHeart webinar to provide an AMA PRA Category 1 credit to participants both in person and online. Our presentation today is Mind-Heart Connection, Why Do Women Have More Dementias? I am Elaine Vining, Senior Director of the National Hospital Alliance at WomenHeart, the National Coalition for Women with Heart Disease. I am also joined by my colleague, Milan Anderson. In a moment, I will introduce our distinguished expert presenters from Rush Oak Park Hospital. Let me please ask everyone in the audience to turn off their pagers during this presentation. I want to welcome to our in-person attendees at the Grand Rounds, as well as to the WomenHeart National Hospital Alliance members and participants joining us online. We are very pleased to have Drs. Annabelle Volgman and Dr. Neelum Aggarwal present on this important and timely topic. Dr. Volgman is a clinical cardiac electrophysiologist, a professor of medicine, and the medical director of the Rush Heart Center for Women at Rush University Medical Center. Dr. Aggarwal is with neurology and is an associate professor of neurological sciences. She is the director of research at the Rush Heart Center for Women. I want to begin by saying how very appreciative we are for your time, your energy, and your commitment to helping women around the country with or at risk of heart disease. We all know this is the #1 cause of death in women. The collaboration between WomenHeart and hospitals like Rush Oak Park to engage clinicians, patients, and the community in raising awareness, expanding education, and sharing support will help all of us change the trajectory of this heart disease in women. There is a growing body of research about the association and contribution of heart disease to cognitive decline and dementias. Raising awareness about the connection between heart disease and cognitive decline in women is key to addressing the problem. During this webinar and Grand Rounds, presenters will provide clinical data related to heart disease that can cause cognitive decline and dementias. They will discuss the association of atrial fibrillation, strokes, and dementia in women, and share and discuss ongoing studies that can help understand the heart-mind connection. Just a couple of housekeeping moments. This webinar will last approximately 60 minutes. We will have a question and answer session in the last 15 minutes of the webinar, so you can ask our presenters any questions you may have. Please note online guests who wish to receive 1 CME credit for this presentation must remain logged in for the entire presentation in order to receive the credit. Upon completion of the webinar, online participants will be emailed a SurveyMonkey evaluation to complete. You must complete this evaluation in order to receive the credit. I also note this presentation webinar is being recorded so you and your colleagues can access it at another time. Once we reach the Q&A portion of this webinar, a slide will be posted with instructions for online participants to submit your questions. We will alternate questions between in-person and online participants. Drs. Volgman and Aggarwal will answer them in the order in which we received them. And so without further ado, let me turn this over to Dr. Annabelle Volgman, who will start the presentation.
Thank you, Elaine. Good afternoon, everyone. It's my sincere pleasure to be here today and to welcome you to the first ever webinar and Rush Oak Park Grand Rounds together. First, I want to thank Bruce Elegant for sponsoring the National Hospital Alliance with WomenHeart. Without his support and without the support of Rush Oak Park, this would not be possible. It also supports the support group that we have for women with heart disease. So if you have any women with heart disease or at risk for heart disease, we have monthly support group meetings here at Rush Oak Park on Wednesdays, the second Wednesday of the month. So if you want to know about that, please let me know. Email me and we can send you those flyers. I also want to welcome the people online. I'm so pleased that you are with us on this day before the 4th of July. I want to tell everyone that I'm celebrating my 27th anniversary to the day I was hired by Rush to start on June 30th, 1990, and I've been at Rush for all those years. And I've been here because I think that this is actually the best medical university center that I've worked at, and I've worked at some really excellent and outstanding centers. But I believe that Rush gives the best care for their patients, and that is my goal in my career. I'd like to give you some background slides. These are some housekeeping slides. Our learning objectives are as follows. We're going to discuss the current data that's associated with the association of heart disease and dementias. We'd like you to recognize at the end of the talk, recognize the association between atrial fibrillation, strokes, and dementia in women. And Dr. Aggarwal will discuss the ongoing studies that can help understand the mind-heart connection. These are our, so I'm going to begin. I'm going to talk about the connection between the mind and the heart initially, and then the specific problem with atrial fibrillation in women, and also statins and ApoE, lipoprotein. And after I give you the problem, Dr. Aggarwal will give you the solutions for all of these problems. Just want to start out by introducing my other colleagues. I'm not sure why this is not showing all of my slides, but I also have other colleagues besides Dr. Aggarwal who actually started with us three years ago when we were talking to the community about the connection between the mind and the heart. And we decided to collaborate because she was very interested in gender-based medicine. And since we started the Rush Heart Center for Women in 2003, we've been collaborating also. So I want to start out with two patient stories. This is my family, actually, in Michigan. And in the middle is my mom, the one in the red. And as you can see, she's in a wheelchair. And she suffered strokes about 10 years ago, and it changed our whole lives. And unfortunately, when a woman has a stroke or when a man has a stroke, it doesn't just affect that one person. It affects the immediate family, especially the spouse, but especially the whole family and the whole support network of that family. This is another family picture. This time, as you can see, it's mostly white people. It's my husband's family. And the matriarch and the patriarch of this family was my mother-in-law and my uncle, her brother, who suffered from Alzheimer's. Fortunately, they lived a long life. She died in her 80s and he died in his 90s. But their last decade of life was really riddled with a lot of problems. They both had Alzheimer's. And when I looked into the problem of Alzheimer's, because I wanted to prevent Alzheimer's in my husband, wanted to live a long, good quality of life with him, it turned out that a lot of the risk factors and the prevention strategies to prevent Alzheimer's were the same as preventive strategies for heart disease. And so in a selfish way, I wanted to study more about the connection between heart disease and dementia so that my family wouldn't suffer the problems of Alzheimer's disease. And this is an interesting look at mortality. This is mortality from heart disease in Los Angeles in January of 1991, 92, 93, and 94. And as you can see, 1994, there's an outlier there. There's a huge spike on January 17th, 1994. Some of you who were around at that time, I know some of you were born after this, looking at the audience, but some of you who were born at the time may remember that January 17th, 1994, was the big earthquake in Los Angeles. It not only killed people from the accidents, but there was a big spike from heart disease mortality on that day. So the stress not only caused a lot of stress from people, but it increased mortality that day. So there's definitely a big connection between the mind and the heart. In addition, we are seeing more and more women, especially postmenopausal women, who are under tremendous stress, such as a loss of a loved one, especially the loss of a child or the loss of a pet. And these women are coming in with signs and symptoms of a heart attack. And what we're finding is when we take them to the cath lab, and I see Dr. Tanis is here in the audience, and I'm sure he's seen this, when we take them to the cath lab to see if we can put a stent in their arteries, we find that they don't have obstructive coronary artery disease. And when we look at the LV function, or the left ventricular function of these women, and occasionally some men will present with this, their hearts balloon out. Instead of contracting, it actually goes out. And so we see this pattern called the Takotsubo pattern. It's a coin from a Japanese octopus catcher, where you see the bottle, the vessel is thin at the top, and it balloons out at the bottom. After a few days of good treatment and decreasing stress level, this actually normalizes after a few days to a few weeks. So it's a very interesting phenomenon where you have a sudden onset of stress that causes this heart attack looking problem, and it resolves after you decrease the stress. What we don't know, it was also coined a broken heart syndrome. And what we don't know is the women who are not coming to the hospital, and they may just actually be dying from this. And so we need to look into this further. So stress and heart are definitely very much related. In terms of heart disease, atrial fibrillation is notorious for causing strokes and and brain problems. And there are gender differences in stroke risk factors as well. So atrial fibrillation is one of the most important predictor of strokes, and so that's a big problem. And when women have atrial fibrillation, they have a higher risk of strokes than men. So it's definitely a risk factor more for women than in men. Other risk factors that are specific to women for increasing the risk of stroke are hormonal status, gestational diabetes, the use of oral contraceptives and hormone replacement therapy, preeclampsia, and pregnancy. Other risk factors that are higher in women than men are depression, diabetes, hypertension, migraines with aura, and of course psychosocial stress. Women tend to have more psychosocial stress than men. We know that atrial fibrillation not only increases the risk of stroke, but we now know that it also increases heart failure and dementias. And it's not just a stroke problem. It seems to be that it's not just the strokes from atrial fibrillation that's increasing the risk of dementia in these people, and we're going to talk about that in the next few slides. But we also know that women are at higher risk for dementia, especially Alzheimer's. So we need to look at that. And I wanted to just show you this very interesting slide. So if a woman or a man is diagnosed with atrial fibrillation, we need to anticoagulate them to prevent strokes. But in the past, we were only able to anticoagulate them with warfarin. So how good is prevention of strokes and dementias in patients who are treated with warfarin? This is an interesting study to show that if you have 75% therapeutic range of that INR, so that your anticoagulation is really good, greater than 75%, you have less risk of getting dementia. But if your INR range is so variable that you're only in therapeutic range, less than 25%, your risk of dying and having dementia, days to dementia, is much higher. So very interesting study to show that warfarin is not a great treatment if you're not anticoagulated well. So the question is, if it's not good to be anticoagulated poorly, how about novel anticoagulants? Now that we have new anticoagulants, that as long as you're taking it, you're anticoagulated, how do those patients do? Well, novel anticoagulants were then studied already, actually, and this study looked at 5,000 men and women, and what they found was that there was no significant difference in the mortality from the novel anticoagulants versus warfarin, but there was a difference, a big difference, in strokes and TIAs in the patients who were treated with novel anticoagulants. In addition, long-term incident dementia was much better in patients who were treated with novel anticoagulants. And so when I have a patient who comes to my office with atrial fibrillation, men or women, I will try to encourage them to be on a novel anticoagulant as opposed to warfarin. So I think that that was a big thing that we need to bear in mind when we're treating patients with atrial fibrillation. Well, how about silent brain infarcts in patients with atrial fibrillation? This study from Japan looked at patients who had atrial fibrillation, and they looked at patients whether they have silent brain infarcts or not. And what they found actually was that the predictor of these silent brain infarcts can easily be evaluated with an echocardiogram. So if they have diastolic dysfunction parameters, or parameters consistent with impaired left ventricular emptying, or what we call diastolic noncompliance, they had a higher risk of silent brain infarcts. So we really need to make sure that we're not missing these patients who come in with heart failure symptoms, but they have a normal left ventricle. If they're coming in with heart failure symptoms, they are actually at high risk for developing these silent brain infarcts. So don't forget to anticoagulate those patients. And so this was just the conclusion that patients with silent brain infarcts had an increased risk if they had more and more parameters consistent with diastolic dysfunction. So atrial fibrillation is clearly a risk factor for atrial fibrillation, whether they have strokes or silent brain infarcts. And this is such a novel field that Dr. Ruskin is one of the electrophysiologists at Harvard, and he's really recognized this. And when I gave grand rounds at Harvard, Dr. Ruskin was intrigued by my grand rounds because this is exactly what I was talking about, and we are now collaborating to study this further. There are now studies ongoing. The electrophysiologists are not far behind in this topic, and there are ongoing studies, many of them, dealing with comparing catheter ablation versus antiarrhythmic drug, patients on novel anticoagulants versus warfarin, and we're looking at systematically at these patients for cognitive decline. So I'm going to turn the topic from atrial fibrillation to statins. One of the reasons why I wanted Dr. Aggarwal to see my patients is because a lot of my patients who I put on statins were complaining of cognitive decline, and they were blaming me for causing their problems because I gave them statins. But when we look at statins and cognitive decline, even though there's a black box warning in a lot of statins, there really isn't any consistent study that show that certain statins cause cognitive decline. I think we need to take people on an individual basis, and if they're having cognitive problems with that statin, we need to switch them to a different one. Another topic that comes up is heritability. Do people inherit the risk of Alzheimer's? And one of the important connections between heart disease and dementia, especially Alzheimer's, is apolipoprotein E. So if you have a genotype that predisposes you to Alzheimer's, such as the ApoE genotype, E4, that doesn't just cause early Alzheimer's, it also causes early heart disease. And I'm showing you these molecules because there are different kinds of apolipoprotein E. This is two of the most common ones, ApoE3 and ApoE4. this one difference can wreak havoc not only in your heart, but also in your brain. And what is lipoprotein E? Lipoprotein E binds the VLDL, or the triglyceride-rich lipoprotein, and apolipoprotein E is essential for binding to the LDL receptors. And if you have the ApoE4 genotype, it will bind to the LDL receptors more tightly than ApoE3, so that you don't have as many LDL receptors to clean the serum or your blood from the LDL. So it increases LDL, it increases cardiovascular risk, but having that genotype also increases the risk of Alzheimer's. So I just wanted to show you the ratio of the population that has apolipoprotein E4. Like I said, the E4 is the worst genotype for causing Alzheimer's and heart disease, but thankfully only 1 to 2% of the population has it. If you're ApoE3 and ApoE4, however, you don't have as high a risk, but there's a lot in the population with that genotype of ApoE4 and E3. So unfortunately, 25% of our population has that combination, and that puts them at risk for heart disease and Alzheimer's. This is one of those genotypes that can actually predict how we respond to our diets. So that if you have ApoE4, alcohol is a huge no-no. You really should not be drinking alcohol. You really should try to stay with a very low-fat diet, and really do as much as you can to prevent Alzheimer's and heart disease. We looked at just one more study. We looked at whether women and men in our cardiology office are interested in genetic type testing, because once you diagnose somebody with an ApoE4, it could be very anxiety-provoking. So we looked at whether there was any gender difference in whether people wanted to know their genotype. And it was interesting. From our patient population of about 600 people, we found that women were more interested in undergoing pre-symptomatic genetic testing, whether they're having symptoms or not, or whether there is a cure for it. They were more interested than men, and that may have something to do with the fact that they're worrying about their children. So with that, I'd like, now that I've given you the bad news, I would like Dr. Aggarwal to give us some good news and give us some ideas of what we're studying at the Rush Heart Center for Women. Dr. Aggarwal is our neurologist at the Rush Heart Center for Women. Thank you, everyone.
Thank you. Okay, so I'm guessing I'm like the cleanup person, right? I come up here to talk about where we are right now with dementias. And, you know, I have to say, this is really a pleasure to be here, because when you hear, we're able to make links. So this is what we have to do a little bit more in medicine, making links between what we're seeing in one field and how is it translating to another, and what is the research coming in the other field. A lot of times we don't know what's the latest. So my thought here is to try to give you a whirlwind kind of overview of what's happening in the dementia space. And as you all know, we are aging, and the prevalence of dementia is increasing. It's increasing not through the U.S. only, and worldwide. It is a worldwide phenomena, and you may be surprised to see that the fastest growth of dementia and Alzheimer's disease right now is going to be in Asia. So Asia is going to be hit the hardest, and when I say Asia, it's Asia inclusive. So it is China, Japan, India, Philippines, the whole Asian Pacific area is going to be hit very, very hard with Alzheimer's disease, and they're already seeing the shifts going on. The other thing that Annabelle already alluded to is that women are developing Alzheimer's disease at a higher risk than men. And, you know, every time I say that, the question always comes back, well, is it because women are living longer than men? Part of the answer is yes, but we now know that there are biological differences that are going on between women and men, and therefore that could be one of the risk factors. Just again to refresh everyone's memory about when I say the word dementia, what is a dementia? As a neurologist, I think about dementia in terms of, and thinking in terms of domains. How well are you thinking? And the domains, as you can see, are memory, language, orientation, judgment, attention. This is how we tend to think about cognition. And the issue with Alzheimer's is it's short-term memory that is really the first thing that is affected with people. If anything else is affected first, we're not really thinking Alzheimer's dementia. We have to do a little bit more investigating. Late onset Alzheimer's disease, you heard Annabelle talk about ApoE. This is the gene, if you will, for late onset Alzheimer's disease. Early onset are different genes. And the basically vascular disease now is really coming to the threshold. So as a neurologist, this is what I think about when someone presents with memory issues, and you can see through here that the majority of the cases are falling here, okay? AD, Alzheimer's, and then vascular related. I want everyone in the room to get comfortable with this term mixed dementia. It is a relatively new term. As neurologists, we never really like to say that as much. We wanted to say Alzheimer's, we wanted to say vascular. Now we're understanding that we're seeing a lot of mixed dementias in our patients. And how do we know that? We know that from brain autopsy studies. That when we do the studies at Rush, and we do many of them on brain autopsies, it is very rare that we are seeing only Alzheimer's pathology in the brain. What we are also seeing is that across our diverse populations, not only are the dementia rates increasing, they're increasing in across all of our minorities. And this is increasing across every age group. So it's every age strata that you would think about are increasing. A lot of the population studies are coming out through New York. New York has a very good population study. We have one here in Chicago. But these are the rates that we're seeing. And the Asians are now starting to creep up in this rate of dementia. It's something to keep in mind, because as we start to think about how we're going to treat dementia, we have to start thinking about the race ethnicity differences that may occur, not only with diagnosing but with treatment, and I'll get to that in a moment. Gender and Alzheimer's disease. Well, this has been really in the forefront quite a bit. Women appear to be getting Alzheimer's more than men. And again, it is across all age groups once you go from 65 and older. So this is an important finding that we're trying to understand what could be the risk factors for this. And as you can see, it is a concern for us as women, because you heard a little bit from Annabelle from the genetic perspective about the genetic testing. And when a woman has Alzheimer's disease and goes through genetic testing, what is the implications for the children and for the family? This is a normal brain, and this is an Alzheimer brain. I have to put these slides in. Everybody wants to see what growth looks like. And then when you look under the microscope, you have the typical plaques and the tangles. So the plaques are the amyloid. Apolipoprotein E is basically depositing a lot of amyloid in your brain. And then the tangles are the tau protein. And there is still an ongoing debate as to which one is more important for Alzheimer's disease. We are still diagnosing based on what we find for both, but there is still a debate going on. Is it really an amyloid issue, or is it a tau issue? I am going to tell you one thing, though, that we are seeing changes occurring 10 to 20 years before somebody will even present with memory issues. That has been coming through because of a lot of things like this. When you have certain imaging being done, and you have SPECT imaging and PET imaging, you can already see these are the areas of the brain that are working, and these are not. And with the brain images that look at function, we're able to say this is consistent with or supports a dementia, most likely Alzheimer's pattern. Different dementias will show up in a different manner. Now, one thing that hasn't changed, unfortunately, with the disease are the 4 drugs. So this is one of these diseases where we haven't had much progress with new drugs coming on the market, and that's really the frustration for a lot of the physicians treating, and a lot of referring docs who refer to me. Is there anything out there? Is there anything new? These are the drugs that you're most likely are familiar with. Donepezil, galantamine, rivastigmine, memantine. Now we have combination pills. The issue and the main thing I want to push out here is at 18 months is really what we're looking for with treatment for these medications, where we try to level people off. Now you're thinking, oh my goodness, people have been on these medicines for years. Why are they still on? A lot of times it's the family that wants them on. They don't want to be taken off. And I have to say right now, it may not be the memory issue that the medicine is helping, it's the behavioral issue. So a lot of times the meds are staying on because of the behavior. The behavior is better. They're more alert, but it's not so much the memory. Okay.
All right. So if you think about where we are, we have 4 medicines. We really don't have the cure right now. And as a neurologist, that's very problematic for me to say that, because I really want to say that we have a cure in the horizon. But what's happened in the research world and now coming into clinical, this is the important part, coming into clinical, is that we are now looking at preclinical stages of Alzheimer's disease. This is the timeline where we're at. And by the time someone will come to present with cognitive impairment, probable AD, you can already see this age, but look what's going on already before we get to the age of 65. We have a lot of changes going on in the brain and a lot of pathology. So the research is really focusing on disease studies, medications, drug development that are really going to try to hit it at prevention, modifying before we get to the disease. And that is where the dollars are going. That is where a lot of the research funding is going. If you want to see another visual presentation, you can see what happens here. Again, amyloid deposition is already starting around 40. It's already happening in the brains right now. And as you go further along, other things start to happen, which are the tangles, and then the neuronal loss, which is in the brain itself. So we had a revamp of our diagnostic criteria for Alzheimer's disease, finally. Finally, after 27 years, it was a final revamp of how we are looking at Alzheimer's disease. And it was really done in a strategic manner, because what we were noticing is the neuroimaging has just taken off. The biomarkers have taken off, and yet the diagnosing was only being based on clinical, basically recognition of the disease. And we had to start to bring in, how are we going to bring the biomarkers and the neuroimaging together to help us in making the diagnosis? And I think this was a really important thing to do, because it had the 4 main goals, was really to figure out the asymptomatic stages, relate the clinical to the pathophysiology that's there, and then relate these to personal treatment. If you notice on every single bullet, I put down sex and gender differences, sex and gender differences. And I'm really stating this here to this group and whoever and everyone who's listening. We have got to start thinking about how are we treating this disease as it relates to sex and gender differences in presentation, adherence to medications, adverse events, how does the brain look? We need to start thinking about and answering these questions. Now, Annabelle already has gone through what is happening in the cardiovascular space and why neurology is now getting into the space when it comes to dementias. And again, it's the biggest things that are driving right now, honestly, are diabetes. Diabetes and dementia are getting to be very strongly linked, to the point that if you're a diabetic, your brain looks different than someone who is not, and dementia is basically hastened and accelerates with diabetes. And I think that's an important thing given the diabetes rates that we have here in the country. This slide is really just trying to show you now how we are thinking about prevention of Alzheimer's disease. Asymptomatic Alzheimer's disease is a term that you need to be aware of, because we're using it more and more. And a lot of times the clinicians initially did not want to use that term. What do you mean asymptomatic AD? What are you saying? What I'm saying is the biomarkers and the neuroimaging is going to help us identify which people are at risk of developing Alzheimer's. So if you take a look, down here is where we're focusing, because we know these are the protective factors and we know these are the risk factors. And again, it's not anything that seems to be, well, that's earth-shattering, but it is earth-shattering in the sense that we're making the links now and trying to show how these are affecting the brain through the biomarkers and the imaging. When we started to do this work, it was very apparent that we have a condition called mild cognitive impairment, which is in between normal thinking and Alzheimer's disease. And when you have Alzheimer's pathology and vascular pathology, there is this area in here which is really called MCI, another term that has to be used in the offices when you see someone that you're thinking they already have some mild signs of memory changes and loss. Get used to saying the word MCI, because it is an entity that is truly there. And we see a lot of people who have that. And the reason why we're interested as neurologists about this is that this is where we want to intervene as much as we can before we start to get here. This is where a lot of the clinical trials are going. They're looking for people who have very mild issues but are able to function in every aspect of their life, but memory, short-term memory, just may be the issue. They are termed MCI. So you're going to say, and I hope you'd say to me, well, how do you know MCI is a problem? Is MCI anything we should really get worried about? Well, we've started to do a lot of neuroimaging, and the type of imaging that has been very helpful is called PET imaging, especially amyloid imaging. And I want to just show you this set of pictures coming, again, from Pittsburgh, where you have a normal person. You have a person now who has early stages of MCI, but you see the red? This is already telling us that there's amyloid in the brain in a very mild person. As MCI progresses, again, no Alzheimer's disease, no dementia first and no Alzheimer's disease. The red is really increasing, and then with the Alzheimer patient, you can see the red is still there. The reason why there is a dropout of the red is because the brain tissue has shrunk. There is no more tissue there, so there's no more red to bind. Okay. So this is a slide everybody wants to see because they're looking at risk factors and they're trying to see what is a risk factor for me and what is something that I can do for prevention. And I want you to notice a couple things. Age still remains the #1 risk factor for developing Alzheimer's disease, hands down. The older you get, the chances of you getting it are high. Women are up there. Genetics is there, and the little stars that you're seeing around all these areas means that there are sex differences in the appearance not only of the disease, but how it relates to developing dementia. So depression, Annabelle talked about stress, but we're talking about depression is higher in women than in men, 2 to 1. And we're looking at distress. What are the rates there for women as it relates to Alzheimer's? Protective, this is what it is right here, social networks, physical activities, and apolipoprotein E2 seems to be the genetics that is really helping us. The bottom line with genetics, and I'm going to spend a few minutes on this, is that right now it's a risk factor. It does not mean you're going to get the disease unless you have early onset AD and the 2 genes are presenilin 1 and presenilin 2. The other types of Alzheimer patterns are sporadic. They just happen. And that is something that is very hard for families to understand. Why did it happen to me? Nobody ever had this. Well, the terms may not have been Alzheimer's way back. It could have been senility. It could have been hardening of the arteries. But the point is that it's really most of the cases are blue, which means out of the blue cases, they're sporadic. We do know, though, that family history is something we take seriously, and especially now as we're seeing between African American and whites. We do know that in African American families, when there is a family history being given, it is quite often something we need to pay attention to because there is a chance of developing Alzheimer's disease higher than in white families. And it basically comes to African American women more than white women, African American men more than white men. Do we know about these trends with our Latino population and our Asians? Not yet, but we're trying to understand if this is also holding true. So we do pay attention to family history, but again, it's not something right now that we are routinely screening for in the office. Most neurologists are not screening for genetics in the office, and if they are, a lot of them it's because it's an early onset case and they're not sure what the diagnosis is. Annabelle mentioned about apolipoprotein E and the E4 copies, and I just wanted to show you this slide because the question is risk, right? What is the risk if I have this? Here it is. If you have no ApoE4, age of onset for developing dementia and Alzheimer's would be around 84, it could be. Okay, prevalence 73%, 20% with Alzheimer's, but the age of onset would be around 84. Look what happens when you have 2 E4s. Prevalence in the population is 3%. 91% will have Alzheimer's, but the age of onset will be 68. So that's what the risk, that's how the risk is translated, and that's how we talk about it, that you are now lowering your age of developing signs and symptoms. As I mentioned about biomarkers and what we're doing in the field with research, this is the slide that is often presented at our meetings to show you it is not just brain imaging, it is spinal fluid that's being looked at, the amyloid is picking things up early, the FDG PET, the MRI, but look at this, cognition, green, and function are way over here. All of this stuff is happening before we even see a patient in the office. So what are we going to do about that? That should be the next question. What are you going to do if we know this? Well, the A4 study is a landmark study that we're doing at Rush here. It's a study that's being done across the country where we're looking at giving a drug against amyloid in asymptomatic people, people who do not have memory issues at all. These are the folks that are going to get this drug. It's going to be a placebo-controlled drug, trial, but this is a study for the first time ever we have ever brought people in who do not have any cognitive issues for this study. The other thing that we just finished recruiting for is an insulin study, nasal insulin. People who have MCI, that intermediate stage, we have been giving them nasal insulin twice a day to see if we can slow down memory issues because there's a dysregulation in the brain of the sugar, the glucose. And we're looking at giving insulin. And the other study that we're looking at doing here is the MIND diet, the MIND study, which is going on here at Rush Oak Park. This is the MIND diet, combination of a DASH diet and a Mediterranean diet in people, again, who are not having any signs of Alzheimer's, but have a genetic history in the sense of family history, and are not exercising. And that's what we're doing here now to see if a diet will slow down the progression. And then the last study that we're doing is the EXERT study. This is a study of exercise. And exercising in people who have MCI, already mild issues. We're exercising them. And what are we doing? We're doing aerobics exercise 4 days a week with a personal trainer, or we're doing stretch exercises 4 days a week. And we're going to compare how does the brain change with those exercises. That is being done at the YMCA in Evanston because the trainers are up there for that study. But I think, you know, these are all things that are important because we're trying to see how these changes are going to, in the brain, are being affected either by diet, by exercise, or by drug. And this is all, frankly, in the pre-symptomatic stages or the earliest stages, which are MCI. So I think right now, this is really what we want to look like at 90s. This is a favorite slide of mine from Dr. Volgman. And I'm going to open it up for questions, but this was kind of an overview of where we're taking the knowledge from cardiology and the vascular risk factors, and now we're trying to modify them to see how it's helping with brain functioning. So we're trying to make that link. So with that, I'm going to close right now and take questions.
Thank you so much. Thank you very much, Dr. Volgman, Dr. Aggarwal. That was fascinating and frightening. So thank you. Now we will start our question and answer portion of the webinar and the grand rounds for about the last 15 minutes. Here are the instructions online for our participants to submit questions. It's also on the slide in front of you. But go to your webinar, just for the folks online, go to the GoToWebinar control panel, locate the box with the question mark icon. That is the box to submit your questions. Type in your question in the box, click submit or enter. Your question will automatically come to Milan and you will not be seen by anybody else online. I will read the questions and I will read the questions out loud, and in the order we receive them, alternating questions with folks in the audience here, and then our panelists will answer them. So go ahead, please locate that box online and ask your questions, and if we could start with the audience here. We'll just repeat the question so that people online can hear it as well.
Any questions from the audience? Yes.
I have a question. Because you talked about, well, both of you, the relationship between diabetes and dementia. Is the relationship like your diabetes is more out of control, the dementia will be worse, you know, like the higher your hemoglobin, the more severity it presents?
So I'm just going to read the relationship between diabetes and dementia, and if the diabetes is significantly higher, will dementia be higher? Thank you.
Right, so that's a great question, and the answer is yes and yes. Yes, that if the diabetes is out of control, the cognitive changes are occurring worse, and you have to be careful because then it gets into a delirium, right? So people can get into a delirium with high sugars. The bigger question, though, is the pre-diabetic state that a lot of people are in, and where are we? We're looking and seeing already changes in that state causing cognitive changes and bringing on more of an MCI picture, hastening there, and then going into dementia. So control your diabetes, absolutely, but pay attention to what your A1C is, where you are running, and that's why I'm always say this, everyone is pre-diabetic. So it's a matter of honestly trying to keep those numbers in check because we're already seeing changes in women over time. Yeah. We're just going to take a look at the panel.
The other questions?
So I have a question here for the audience. How many of you take care of somebody or know someone who has Alzheimer's disease? Okay. Yeah, so, you know, Dr. Volgman and I were very interested in, you know, doing studies at the center that really try to tap into what's happening with our patients. And the caregiving issue is coming up full force. And I think, you know, I talk about this because I was just at a meeting where I said, caregivers are patients. It's not this entity, you're a caregiver, you're somebody's patient. And with caregiving, we know caregiving stress and burnout is causing more issues for the caregiver from caring for someone with dementia than the dementia person. And so as a physician, I see the burnout of the caregiver far faster and worsening than the dementia patient themselves. So a couple things we're doing at the center is that we're enrolling patients of Dr. Volgman's who are caregiving and also have heart issues into an online web-based program to learn how to caregive. It's online. It is not going to meetings. It is not doing any of those things that for a caregiver are just so not reachable. But it's online and it's using videos, it's using all these different modalities so that at 2 a.m. if you need to understand what to do, if there's roaming and if there's talking and if there are all these things, you can go online. And this is where we're trying to get telemedicine coming in and telehealth. So there's a study, if you're interested in, let us know. It is something that is very important to us because we're worried about heart disease. She's seeing escalation of heart disease and worsening with the patients. I'm seeing the stress, and the stress saying I can't think right. I can't function. I can't remember. Am I developing this dementia? And a lot of it has to do with that stress factor. Okay, so.
There doesn't seem to be any questions from the webinar. Any other questions here?
Yep.
Yes, Kathy.
When you showed the risk factors for dementia, any risk factors, smoking or alcohol use, is that increase your risk of dementia? And then the second part is just more about how do we get, can you guys send out an email with the links or the tests that you want to for patients?
Sure. So, two-part question. Is there any relationship between smoking and alcohol use and dementia? And then second, could the resources for the study be sent out to folks?
Okay. So, you know, the answer for smoking, I have to say, is bad for you. It's bad. But, you know, it's interesting with, well, it's bad, I got to say it.
Flash news.
Yeah.
It's bad for
I
you.
have to say that because the issue is that a lot of some of the studies that we've done where we've looked at nicotine and smoking, it's been a way been neuroprotective, okay? It's everything else, and I know, that's why I'm saying smoking is bad. It's really basically what is in the cigarette, everything else. There is a study going on right now that is looking at nicotine. It's nicotine patches in people who have mild memory issues to see if that will slow things down. Again, it's that nicotine piece, okay? So smoking is bad, just to hit it again. The second thing, the drinking is a tough one. Drinking, you know, we always ask the size of the glass, right? You don't ask how much you drink, just show me the size of your glass and what you drink. Drinking is also out there as far as is it bad for you or not? So here's the rule that I normally tell my patients. 1 glass, show me the size of whatever you're going to have a night, fine. But when there's already a memory issue going on, and already I'm seeing forgetfulness going on, the alcohol obviously makes it worse. Now, we have an issue of how much people are drinking prior to coming in, and having a cocktail every night, and can I have a glass of wine? If that is part of the lifestyle with food, notice how I say food and activity, it's part of a healthy lifestyle where people enjoy a drink. But when it is by itself and it's coming into I'm not eating, I do tea and toast, which is one of the earliest signs we see with people who are beginning to have memory issues, they stop eating. It's tea and toast all the time. There's not a meal. So what I would say then, I would say it's bad for you. And I tell people if they can pull back, pull back. And then the last thing I do say, because it's tricky, if I'm going to start you on a memory medicine, I really do not want you to be drinking because I don't know what the reactions are going to be between the two. Now, am I okay with that? Are people doing it? We just have to follow it, but it's a tricky question with alcohol. The other thing I want to bring in here while we're waiting for questions is head injury. Head injury is huge right now, and I have to kind of talk about that from a neurologic perspective. The amount of falling that is occurring in the homes of people, forget about the hospital, in the homes is it's just incredible how much falling, and it's always underreported. It's like the smoking and the drinking. How much do you falling is underreported. I want everyone to think about falling as being a mild TBI. Get used to saying the word MTBI, mild TBI, because a concussion, traumatic brain injury, mild traumatic brain injury, we're using that a lot in neurology. Concussion, getting a daze, it's very important. We don't even know the implications of these little falls. We don't know that. We are still trying to figure this out because we cannot get sometimes accurate information, but the cognitive testing is already showing the slowness in the thinking and the processing. We do know if you fall and you have ApoE4 and you have this mild TBI, it is a bad combination. And it can hasten the effect of MCI and dementia. We're seeing that, and we're now beginning to look at the sex differences with concussion in men and women, and there are many differences, and we seem to feel women are going to have a poorer outcome after a mild TBI than a man. Okay, and that we have to figure that out a little bit more. Is it a hormonal thing? What's the age distribution? But keep that in mind, that this concussion and head injury is very, very underreported. Very underreported, and we're seeing a lot of it in our older folks that are coming in through falls.
I think we are good. Thank you so much. Are there any last questions for our presenters? Well, let me thank you very much. It was incredibly informative. It was incredibly powerful, and we are glad to be, as WomenHeart, the National Coalition for Women with Heart Disease, it is an incredible partnership for us to have with you, so thank you very much. I invite folks here, and I invite folks to take some information from WomenHeart about women and heart disease for your patients, for your family members. It is an organization that we hope you will find as a resource. We look forward to working with you all. And I want to thank everyone who was present for the Grand Rounds and the webinar today. If you have any additional questions, my email, Elaine Vining, will also be in the follow-up email you receive at this time. Just as a reminder to our online participants, you will receive a Survey Monkey evaluation in which it must be completed by the, I think we said the 10th of July, and you will, in order to receive your 1 CME credit. So please be on the lookout for this in your email. Also, you will follow, as a follow-up email, you'll receive a link to the webinar recording in case you want to watch it again or share it with any of your colleagues. Thank you so much to Dr. Aggarwal and to Dr. Volgman, and we appreciate your time and everybody's interest. Thank you very much. This concludes our webinar.